from a position where I'm a burnt-out hospital clinical pharmacist. I was a clinical pharmacist for 30 years in the NHS hospital, so I've been on the receiving end of bad prescriptions for an awful long time, and a few observations. I'm going to start off by just making a quick comment about the GMC report, because it's actually quite interesting. When a bad thing happens, when a bad prescribing error happens or administration error in a hospital, normally a senior manager or senior clinician is trotted out in front of the media. And what do they say? They say, well, this is, really very bad, and we're going to do some additional training, and this will never happen again, okay? And actually, what they're indicating is the two myths in healthcare. And the first is the perfection myth. That is, and this is taught in medical schools, nursing schools, pharmacy schools, if people just try hard enough, they'll not commit errors. Backed up by occasionally the punishment myth, which is, well, we don't have too many bad apples in this barrel, but when we find one, we'll make sure that we'll send them down the road, okay? And I'm just a bit worried that this GMC sponsored report, and I welcome the emphasis on training and education, but somehow training and education is going to re-establish the balance, which is the perfection myth. Maybe the doctors have just dropped off a little bit, but a little bit of extra education and training, and we'll have them back on track. And the other thing that I find of the GMC is that whenever I read their judgments, it's always the issue about the individual. What that individual did, the bad apple, rather than the system within which they work. So one of my big messages is we've got to learn from the other safety critical industries, and they have found that focusing on the individual's performance isn't just the only thing. It's the system in which they work. And the GMC study, great though it is a bit light on system, and it's very focused for educationalists, which is great, but is only part of the answer. So it goes through, here's reasons for errors occurring in any industry, and education is only part of the answer. Slips and lapses and violations, well, education only has a part to play in those things. The people in NASA have tried to train people that they can't make slips and lapses, and you can't. It's part of the human condition, okay? What I do in my organization, this is from air safety, the idea is increase incident reporting, get some learning, and feed that back. Can I just ask the audience, who's reported a patient safety incident in the last 6 months? Hands up. Yeah. Doctors aren't very good at reporting. There's an interesting issue about culture. We report our findings in these sort of reports, safety and doses. All this says is we get around 100,000 incident reports a month, actually, and about 10% is to do with medication. The numbers of incidents of reports from medication are increasing in the NHS, as you can see. And most of those come from acute hospitals. 76% of the incidents we get in the NPSA on medication relate to acute hospitals. And yes, there are a lot of medication errors out there, and actually you can really dissipate your energies if you go chase all of them. And many of them are never going to cause any harm. And actually, let's just focus on those that are high risk that are actually going to cause harm. And I don't know if that comes over enough in the report. Medication errors are common, but actually we've only got enough time to focus on the ones that can really cause harm. Now, our reports are mostly the no harm, low harm type, but when you read those reports, they're a fantastic qualitative database. It starts to tell you the resilience of the human body to withstand insult, and actually how lucky we are that things actually don't go worse than they do. Administration is the #1 type of incident we get, followed by preparation and dispensing, but prescribing is right up there alongside monitoring, and other tends to be documentation issues, particularly with controlled drugs. So what are the top 3? Wrong dose. Wrong dose and strength by far is the most common incident that we see. followed by, and you wouldn't normally get this, people wouldn't imagine this, omitted medicine. Omitted and delayed medicine, massive. People sitting in hospital beds, not getting IV antibiotics, not getting anticoagulants, not getting their antiepileptics, massive. Followed by wrong drug, wrong quantity, mismatching, etc. Other important messages is that injectable medicines are the ones that kill most people. So errors with injectable medicines. Why is that? How are injectable medicines prescribed? Well, you might just get the drug name. You might just get so many milligrams and the route. It may not always be the right route, but you certainly don't get what to dilute it with, what volume to make it up, how fast to administer it. That's all kind of taken, that somebody else out there knows about that, because it sure as heck is not on the prescription. And when you ask the prescriber, they often don't know that kind of information either. Types of therapeutic groups. Cardiovascular medicines in this report was number 1. By that I mean oppressor agents in ICU, beta blockers. There was a death with too many beta blockers, resuscitation medicines, but then anti-infectives, opioids, anticoagulants, chemotherapy, insulin. Those are the things that are killing people in hospital. We look at this information, we produce medication safety guidance. There's a whole raft of it. Yes, it always contains an element to do with education, but there's an awful lot to do with systems, defining responsibilities, defining safe methods, and saying just because you've got a protocol, make sure that people know about the protocol and operate the protocol. The colleague from general practice, absolutely right. Can it be right that we've got a system where repeat prescriptions are signed 70 at a time? So when we identified anticoagulants and the need to check whether the patient had even been to the clinic, had their INRs tested, GP colleagues of mine said, oh, blinking heck, does this mean I've actually got to read the prescription before I sign it? Or maybe I'll get the receptionist just to produce a pile of those prescriptions I actually have to read, as opposed to those that I sign and I don't read. Now, is that system, no matter what education you have, that's a poor system, as is discharging patients, with 10 minutes notice. No matter what education you have, a junior cannot do all the things that they need to do to discharge a patient safely in 10 minutes. When I was a chief pharmacist, I would always work as a resident pharmacist during the summer period when there was a changeover, and I would do everything I expected my juniors to do. And I would suggest consultants in the audience do a couple of shifts as a junior, okay? You don't need a great deal of knowledge, just so you'll be okay. Just do a shift as a junior and see if you can operate your own SOPs. Because believe me, it's impossible to do what's expected with those SOPs. So a reality check, please. Go and do what you're asking your juniors to do. If you can do it, then they can do it. But the chances are you'll find very quickly that what they're being asked to do within the time given is totally impossible. Okay. So we are going to give out some additional guidance in the new year on omitted and delayed medicines. And I'm not sure this is a big issue for education and training. It's to do with systems. It's to do with having the thing prescribed when it needs to be prescribed. And I'm concerned about the staccato nature of modern healthcare, where there's a different health professional every shift. There is no continuity of practice, even in general practice. I've got a practice of 8 doctors. I never see the same GP twice. It's always, this is the new practitioner. They don't know anything about you. They're going to do the best they can in a very short period of time, and then they move on. So omitted and delayed medicines, number 1. We're going to do something on insulin, and indeed insulin is our number 1 project for 2010. So getting to the kind of take-home messages, what are the root causes of prescribing errors from my perspective as a hospital pharmacist and working in the NPSA, looking at all those many tens of thousands of reports? It's poor systems, first and foremost, poor systems. and knowledge of the system that's supposed to operate. There's a feeling amongst medical staff, it's the relationship between me and this patient. The fact that I'm in this institution, well, I'll be in some other institution in a couple of months' time, so maybe I don't really engage with what goes on in this institution. I just take with me my practice, and I'll operate that wherever I find myself. And I was at a meeting of diabetologists yesterday, and they were talking about how to treat diabetic ketoacidosis. And the lead consultant on diabetes was saying that so many specialist registrars come in and want to operate a completely new system for treating the ketoacidosis. And she was saying, look, we're on the same page here. The whole team knows how we manage this. Do not come in and upset the apple cart. Learn the system that you're in rather than the one that you were operating down the road. You have to kind of work as part of a system, not as an individual. So SOPs, availability of information on medicines, gone are the days of the white coat and the BNF in the side of the white coat. I don't know where people get the BNF now, but it doesn't seem to be very available, and certainly everything you need is not in the BNF. It's too thick. The design of prescription forms, yes, okay. I've designed a lot of prescription forms in my time. The NPSA will do the national prescription form if that's what's needed. Very little evidence, actually, to show that it's a lot of benefit. There's one paper from Australia where they included an anticoagulant design in the general inpatient prescription form. There's a national prescription chart in Wales. I often, when people say they want a national prescription chart, I send them the Welsh one, and they say, do you know what? Great chart. If we could have the following 10 changes, I could use it in my hospital. And actually, every hospital will want 10 different changes. Interesting to see if people will accept a national prescription chart, but what they do in Wales and Australia, that's even more important. They have training to go alongside the chart, e-learning and other sorts of training, and national prescribing standards, not just the first couple of pages in the BNF, proper standards that people have to abide by. Calculations, double checking, very interesting. You read the report and it's all about self-checking rather than double checking, and Royal College of Anaesthetists just at the moment are looking at double checks on anaesthetists. Can you imagine? Anaesthetists actually saying we might need a second check, we don't always get it right first time. And so the idea of a second person checking, not just self-checking, can be important when it's mission critical. Communication, yes, we've talked about reconciliation on admission and discharge. And I would say to seniors in the audience, just go and do some, admit a few patients, see how long it takes to get a really good reconciliation, and see how, along with all the other duties a junior is supposed to do, whether you can do a good job. And maybe we need to do it in a different way. Effective communication about medicines on discharge, is it possible with the systems you've got in place? And effective communication about medicines from senior doctors to junior doctors and the MDT. I've got to actually pick up, poor European medicine legislation, okay? If you look at the medicines legislation, they're focused on perfection myth, right? If it's in the SPC, that's all that's needed, right? Insufficient focus on human factors and safety in practice within European medicines legislation, written by a lot of laboratory scientists, as far as I'm concerned, not in the real world. They need to take a kind of reality pill in some of the things that they produce. Look-alike, sound-alike medicines. Here's an obvious example. How can they produce all these medicines that sound alike and they extend the range? Insulin is the worst. The diabetologists were telling me yesterday, who allows all these name extensions? Well, the regulatory process enables that to happen. Complex products, complex product ranges. There's a new thing about risk management plans within the legislation. Very few initiatives to prevent medication errors. So if you go through the risk management plans from the companies, no understanding at all about how the impact will that have in the real world, dealing with human beings rather than robots. And finally, education and training and competency assessment. Yes, welcome it. Better pharmacology and therapeutics, better patient safety and human factors. How many of you had any training at all when you were in college about when you made an error? not from this medical school. You know, none of our graduates would ever make an error. You know, we're not preparing people for when they make an error or indeed when they encounter an error. So we need a lot more patient safety training and then practical skills and experience to prescribe safely. Thanks very much.